There's been a lot of recent work in the area of post-discharge AKI outcomes. A lot of that work coming out of Canada and from the VA system from several groups. And what we've kind of found is that people with kidney injury in the hospital, whereas in the past we might have thought that if they creatinine recovers to normal, they do just fine, we found that they actually do not do nearly as well as people who did not have acute kidney injury in the hospital. They have much higher rates of chronic kidney disease and end-stage renal disease, which might be expected, but also surprisingly higher rates of cardiac disease, which is kind of what we focused on in this study, and higher rates of death. So this is a group that's at a lot of risk when it leaves the hospital, which previously was not really identified as a high-risk group, I don't think. We didn't look specifically at mortality, so we have plans to ultimately look at people who developed kidney disease, people who developed mortality, and in this one we were interested in heart disease, actually, people who developed readmissions for heart disease following an acute kidney injury. And we defined a cardiac readmission as myocardial infarction or congestive heart failure or ischemic stroke. So those were kind of our three outcomes. So we looked primarily at risk factors for readmission with these cardiac indications. And I think perhaps this is unsurprising, but I think what struck me was that the people that already had congestive heart failure, atrial fibrillation, myocardial infarction were significantly more likely, as were people with higher baseline creatinine and diabetes. So I think that what that kind of suggested to me anyway, is that there's this group of people that we know are at high risk based on the fact that they've had AKI and they have existing heart failure, and they're not, as far as we can tell, receiving the care they need necessarily when they leave the hospital. So I think this is a group we've identified that needs closer follow-up when they leave the hospital in order to prevent some of these complications. So I think there's quite a bit, and there's increasing literature about what exactly should be done for these people. It's been demonstrated that close nephrology follow-up especially is useful in preventing readmissions and development of disease. But even things like making sure that people are restarting their ACE inhibitors when they leave the hospital, which are often stopped in the setting of kidney injury, would be one. And making sure that patients are not becoming edematous or volume overloaded, making sure that they're meeting all their guidelines in terms of statin use and these sorts of things. I think there's a lot we can do in sort of optimizing medication and just keeping a close eye on the clinical status of these patients that can do them quite a bit of good in the long run. To wrap up, I think this is a group that's clearly at high risk. It remains to be seen if they're at risk because of the acute kidney injury episode, or if they are a group that was already at risk as evidenced by the acute kidney injury episode. So there's a lot of exciting work still to be done in the field, but I think at the very least we can say this is a group that is at high risk, that isn't sort of identified as such, I think, broadly in the community, and these people should be targeted for closer follow-up than just your typical admission, I would say.